educating the physicians, the OR staff, even sometimes med-surg nurses to understand this is not necessarily one physician's actions, while doing that, maintaining HIPAA, but explaining it in a way that makes that NHSN very specific conversation with that language of PATOS very plain, very easy to see. And yeah, maybe lunch may not be a good idea to be talking about feculent peritonitis, but I don't know, healthcare professionals, we kind of like talking about poop while we're eating. So, I guess you should be careful with who you're talking to, but yeah, maybe not the C-suite.
Clock in, scrub up, and join us behind the red line, where infection stops and information starts. You're listening to a special combined season of First Case and Transmission Control podcasts, bringing perioperative practice and infection prevention together to tackle one of healthcare's most persistent challenges, surgical site infections. Each episode will connect you with frontline staff, perioperative leaders, infection preventionists, and healthcare innovators sharing real-world strategies, stories, and solutions that are changing the way patients receive surgical care. From the back table to the boardroom, from wheels in to wheels out, and from surveillance data to safer practice, we're breaking down silos and strengthening the systems that protect surgical patients. Welcome to Silo-Free Surgery.
Hello and welcome to another episode of a special combined season of the First Case and Transmission Control podcast. Today we're talking with Emily Barnard about all things PATOS. PATOS, present at time of surgery, is a super important part of the surgical site infection surveillance process. Whether you're coming from the OR side of the picture or the IP side of the picture, great insights shared for how to break these silos together. We'll be right back after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome back to another episode of a special combined season with First Case and Transmission Control. Today we're talking about a topic that starts with an acronym, PATOS, or PATOS. And you've probably heard it in your OR meetings. You've definitely heard it in your SSI review meetings, but today we're joined by Trey Morrow as our co-host today. Trey, how are you?
I'm good. How are y'all doing?
Good. We're good. And I'm excited to talk about this because our expert on PATOS that we're going to bring in from the IP side is Emily Barnard. Emily, how are you?
I'm well.
Thank you. This may be a topic for our First Case audience. Again, this is going to be a ton of new information, but it's going to be helpful because we're going to get into the nitty-gritty of surgical site infection surveillance, and that's going to arm you with information about how do I talk about documentation? How do I go through, reminding my surgeon to put that in the op note? And so from this episode, it's going to be super, super IP-based, but stick with us because it's going to be valuable for both audiences today. So without further ado, Emily, for the 5 people in the audience who don't know you and don't know your work and experience, tell us about yourself, your career, and what you're working on.
So first of all, I want to say thank you for having me. I'm really excited to be here. My pathway into infection prevention diverges from the nursing route with a background in cell molecular biology and physiology, a master's in public health with a certificate in epidemiology. And I'm currently pursuing my PhD in public health. I'm in the dissertation phase. I've earned multiple certifications in infection prevention, sterile processing, and healthcare quality. I've spent more than 20 years in healthcare, and as an infection prevention leader, I'm also an educator, consultant, and speaker. And I've had the opportunity to lead impactful change management initiatives across multiple departments in both large academics, medical centers, and rural critical access hospitals. Through those experiences, I've learned that improving patient care really starts by breaking the silos. Infection prevention isn't owned by one department or one person, and we're going to talk a little bit more about that. It takes a collaboration, a shared accountability, and a systems approach to create a meaningful change. A significant part of my work has been partnering with surgical services department chiefs, service line leaders, individual surgeons, and sterile processing professionals to mitigate the risk of surgical site infections and other preventable patient harm events. Together, we investigate potential risks by reviewing clinical documentation, conducting direct observations, facilitating one-on-one conversations with frontline staff and physicians, evaluating instrument reprocessing practices, performing comprehensive root cause analysis. And the goal is to never assign blame. It's to understand what happened, strengthen the systems, and implement a sustainable improvements that protect future patients.
I love it. And Emily, I think without knowing it, you hit on our $1 million word for this season, which is silo. And for the audience listening, just some inside baseball here. When we started recording this season, we had a different kind of working title for it. And then each conversation we had, the concept of breaking the silos came up, and how much we're siloed between the OR and IP. And so when you see this come out, you'll see the silo-free surgery title for this season. But that's not how it started. That's just how we came through these conversations and found that it was a really big conversation.
I think that's great, because I feel like when you're working with surgery, sometimes it feels like we're two different departments, but we actually need to feel like we're one. We have one goal to get patients healthy and to make sure that they don't have any complications during their surgeries. I know I've worked with groups where I've gone to the OR and they've in the beginning they instantly think, "Hey, I'm the enemy," but you work with them and stuff like that, and you break down those barriers.
And I think no other conversation affects that dynamic between OR and IP as whether something is an infection or not when it's reviewed for a surgical site infection. And that's where I want to start this conversation is, first off, what is PATOS?
Well, let's take a step back. Let's talk about what a surgical site infection is before we even get started, especially for our listeners that may not be familiar with that. What we use is we use the CDC National Health and Safety Network, which establishes a case criterion essential for us to really understand how hospitals can metric against each other. There's a big disparity between the clinical definition and the surveillance definition. What we use is we use a surveillance definition, and that way we are benchmarked equally across the nation and anywhere else that's using this platform. Procedures that are being performed have a ICD-10 code. This ICD-10 code specifically is associated with billing, and it identifies all the procedures that are being done. Now, when you're looking at specific procedures, they have different surveillance windows. There's a 30-day surveillance window for most procedures, and then most implantables, so like your total hips, total knee, those will be a 90-day surveillance window. And what a surgical site infection is an infection that is identified after that initial surgery within that surveillance window. Now, what about patients who have multiple procedures during one case? So you come in and I just need a hernia repair. It's, umbilical hernia. It's nothing big. However, if you've ever had surgery, I've had a bunch, you actually get this list of things that may be done in the procedure because you don't know what you're going to get into until you get into it. So what that means is as you get into the patient, the surgeon gets into the patient and they start evaluating this hernia. Well, we also need to add the small bowel resection. There's something going on in the patient's pathophysiology that mandates additional interventions. And this is something the patient's been consented for. Now, as you're looking at cases that have multiple surgeries, it goes based on a hierarchical approach as defined by the CDC's National Health and Safety Network manual. Therefore, as you go in for this one thing, it might actually be becoming more specific. However, this is why all that documentation in that operative is so important. As we think about what we're doing here, if a patient develops the surgical site infection, we don't automatically assume that it happened in the OR or that it's a surgeon-specific issue. So maybe an issue with sterility or something else that's going on. We have to really do a comprehensive assessment to understand what is going on with the patient-specific issues, with environmental issues, and then look at the whole systems approach. Now let's get into PATOS. So what is PATOS? PATOS stands for present at time of surgery. So that means there's an infection that's identified at the time of surgery. And we need to ask questions such as, was the infection already present? Were antibiotics given at the right time? Were instruments reprocessed properly? And really think our way through this and engaging all those extra stakeholders, because we can't look at this just for one perspective. We may looking at it through our lens, but engaging maybe a surgical chief, they're going to see something that we won't see with sterile technique, or the operating room, or even EVS. So looking at traffic, do you have traffic coming in and out? So this is again to identify some of these more specific things. Now, what we have identified is that surgical site infections cause significant harm to patients. But identifying that an infection is present at time of surgery, we know at that point that the patient's more likely to have readmissions, more likely to have complications, more likely to need invasive procedures such as the central line and long-term antibiotic use. So with some of these factors coming together, we really have to understand, is this something that the patient had at the time of surgery? And this is based on clinical documentation that is evidence-based practice as established by the CDC's NHSN. There are physicians, there are panels that you can actually advocate to be on to actually be part of these conversations. Every year, at least the NHSN manual gets updated. Sometimes it's in a more frequent interval. And this is based on evidence-based criteria.
You spoke about the criteria. I don't know if y'all have had this before, and I like to bring up my personal experience sometimes with the criterias. Have we ever had surgeons that are basically, well, we're just playing a game with the surveillance versus clinical, and unfortunately, the way that we have to do things, because we have to make a blanket criteria for everybody, we have to use surveillance definitions versus the clinical.
And just because clinically you would treat this patient for an infection, surveillance-wise, it does not drive the treatment process. So again, if you have to think you're going to a physician, okay, you go to your PCP, then you go to your cardiologist, then you go to your EP doctor, electrophysiology. Each one of those is going to give you maybe a different treatment plan based on some process that you have going on. It's the same thing if you go across different states, across different facilities, even physicians within the facilities, there can be a difference between how they would perceive that clinical description.
I'm glad you hit on that too, because that's one of the more common conversations we have with surgical teams is when we bring up, hey, there was an SSI reported, we just completed surveillance, we're reporting it. And you try to give your facility a heads up, before it shows up on their dashboard, just as kind of a courtesy. Sometimes those can creep into like, well, do you have to report it conversations? And that's a topic for a whole other conversation. But I think it's really helpful to have that caveat that clinical definitions and surveillance definitions are different. Not every time we meet surveillance definitions are you treating that patient for an active infection the way that we may kind of traditionally perceive it. The flip side of that is what you hit on, Emily, that these are not just surveillance definitions that came out of, the CDC bureaucrats' rear end. Like, these are actually evidence-based and well-founded surveillance definitions that are based on more data than anybody has available in one central spot. So I think and there was a time that none of these were being reported centrally. And we got here through a step-by-step process of NHSN reporting so that we know what are the trends, what are the realities of SSI surveillance, and where can we make an impact in our own facilities.
And then going from there, like some states report different things. Like I know that Florida right now, where I'm at, we only have to report colos and his. I don't know if it's different in Ohio, where I think you are, Garrett, right? Or California, where I think you are, right, Emily? California, I imagine y'all are probably a little bit more heavy on the reporting.
We have 26 or 28 reportable. Yes, I was actually thinking about you. I have a couple friends in Florida, and you are doing the bare minimum. That is the CMS mandatory reportable colo and his. Now, and that's hysterectomy. Now, as you look at some of those different things, does it mean that some of those other procedures aren't potentially causing harm? Does it mean that your hospital doesn't have the bandwidth? And does it do your physicians and your healthcare organizations a disservice if you aren't reporting those? That being said, do you do surveillance on patients outside of just the colo and his, or is it just surveillance on colo and his and that's all you report?
So, us in general, and I can speak to what I do. I don't report them, but I internally report them to our leadership if they're up. So, and this is going to sound really bad, but in my facility, there's only 2 IPs, and I'm the one that primarily does all the SSIs. So those ones that aren't mandatory reports, I get to them when I'm able to. Like right now, I think I have 100 that I have to still look at, as opposed to when I came back from APIC, I had 200. So my facility does a lot of procedures, so I have to like go through them slowly as time goes on. I don't know. What about you, Garrett? Do y'all...
Yeah, so in my previous organization, there was a really robust SSI surveillance reporting program where we even had where we had a specialized surveillance team that all they did all day was look at NHSN criteria and the information from Epic that came in. And then that information would go to us as site IPs, where we would do secondary surveillance. And then from there, you suss out the opportunities or the trends, and you look at things that are at play in your own facility. Now, the great thing about that is our patients had, I would say, better safety because we were looking at so many different procedure codes with SSI. The downside of that, or I won't call it a downside, but the communication piece with that is for providers, there was some feedback that, hey, when I go up the road to practice at another hospital, I never hear about SSI. And it's like, well, yeah, because they're reporting the bare minimum. But are they catching all of the trends and all of the things that also will impact your colo and hist SSI?
I want to hit on one thing that you just said. By doing surveillance, it requires looking at cultures, looking at readmissions, looking at some of these other factors. Looking at some organizations are more advanced than others. Some have advanced AI that's using rules or algorithms that is feeding you that information. Some smaller organizations, you have to manually go through cultures and pair them and look at readmissions, and you don't have the same pipeline of data. Therefore, it's easier to not have infections if you're not able to capture that surveillance. So based on the robustness of the surveillance at your organization really impacts the ability to have a robust infection prevention SSI program.
Mm-hmm. Yeah, that's a great point too. And it's one of those weird paradoxes in IP that the worst results may not be indicating the worst practices. It may be in a lot of cases indicating that they have better reporting structure. They're looking at more things. And because you're looking at more things, you've got fewer blind spots, and therefore you're reporting more infections. So you always have to keep that in mind when you look at a hospital that says, well, this surgeon has this many infections. And to me, it's a small comfort because it means that they're looking at things. Now, there's tons of caveats that go with that, but it means that they're looking at NHSN criteria and trying to adopt best practices. I'd be a little bit leery about going to a surgeon who had practiced for 30 years and never reported an SSI.
Yeah, and then you also have to look at like accrediting bodies, because like if you become joint accredited, you are supposed to start reporting your knees, hips, and then potentially your backs if you become like ortho and hip. I think it's ortho and hip. I get messed up with the accreditation terminology, but ortho and hip, I believe, is ortho and joint is, I believe, is knees, hips, and back. My facility prior to 2 facilities ago was one of those, and I had to report all of my hips, my knees, and my backs in HSN. They didn't really harm us as far as CMS, but they got put into our internal system.
Yeah, and that's great too, because it's your leadership is getting that information so they can adjust practice accordingly. I think one of the bigger misconceptions when it comes to SSI surveillance and PATOS specifically is that any type of infection that the patient walks in the door with means, hey, they've got an infection, so we're going to document PATOS here. We're going to, and I want to, we'll two-part this. So first, let's talk about that misconception. And then two, if we can get into what documentation for PATOS is actually required. We can't just say PATOS on the chart and say, nope, there's nothing we can do about it. It's just PATOS.
Sadly, NHSN does take if they just write infection present at time of surgery, which is extremely subjective as some facilities are entering as a template EHR, a checkbox. So you just, yeah, they probably have an infection. It's a dirty wound class. Of course. It's a gunshot wound. Of course, there's an infection. But has that infection taken hold at that point? And identifying PATOS is crucial because it ensures accuracy in reporting surgical complications. There's actually a financial penalty that can be imposed on some of these sickest patients that may actually already have that infection. And yes, these patients actually do have to be reported to NHSN, even if the infection is present at the time of surgery. And NHSN is very prescriptive with the epidemiology, the who, what, when, where, how, and it's determined by the surgeon at the time of surgery, and it must be documented in that operative report. Therefore, we must really ensure that the surgical partners, these are our circulating nurses, OR leadership, as well as our physicians, understand what language specifically is allowed. As we're thinking about some of the different aspects of the fair financial reimbursements, we want to make sure that these are correct baseline risk adjustments, not like you said, you can just click a box and say there's an infection present. We really want to have that very specific language. And this is what gives us more robust evidence to really say this is actionable versus this is something that is maybe a secondary effect of the surgery. Because SSIs negatively impact the hospital, they affect service lines, they impact the physician's reputation, they trigger internal physician reviews, and could even result in separation with the organization. This is another reason why understanding that PATOS language is so important. Because yes, it's present at the time of surgery. And what that ultimately means is that if they don't know the specific language, one of my favorites is feculent peritonitis. So you open somebody up, it's an urgent or emergent case, and you see fecal spillage. Well, just because there's been some separation of the bowel for, some rupture of some sort, maybe gunshot, maybe a stabbing, maybe just the patient's own pathophysiology, if they document it that it's necrotic or there's a murky liquid or even just that fecal spillage, that is not enough to have it be a SSI that is present at time of infection. What they like to have is feculent peritonitis. Therefore, you're starting to see some inflammation, which is translating down to infection associated with the fecal spillage. So again, that's the how, that's the what, that's the where. This is where it really becomes a challenge to give them the language that they need to support them in identifying these different components. But a misnomer can be the case is dirty or contaminated. During the case at the deep tissue level, we identified invasive MRSA infection. Well, just because there's a pathogen alone does not mean that it's enough to be a present at time of infection, because you can be colonized with some of these different bugs, especially in the different areas. Maybe it's respiratory, GI, or other areas of the body.
And I'm glad you said that, because for our OR teams listening, you may be doing the work of documenting when you see some of these elements, and then your IP comes back to you and said, hey, that wasn't PATOS. We're reporting this as an SSI. And then you are kind of in that stumped spot of saying like, well, I reported it as I saw it, and there's some support there needed for what language you use, how we document that in the op note, because they are very specific terms. And so as like a go and do from this episode, IPs, OR, go have a meeting together, grab lunch and talk about, maybe don't grab lunch when you're talking about feculent peritonitis, but go through that list of terms from NHSN that meet PATOS criteria so that everybody's speaking the same language.
Yeah, and I love that you talked about how just because it says that they're dirty or it's like a gunshot wound or a stab wound that it doesn't meet. I have that conversation quite often that it's at risk for being an infection, but it's not an infection right now. My first experience as an IP was at a level 1 trauma center, so we had all the gunshot wounds, we had all those stabbings and stuff. And a lot of the times I'd be like, well, they were shot by like 10 bullets. Yeah, it's gonna be an infection. And I'm like, yeah, but it's not really. There's nothing that can classify it as an infection in your op note.
And then going a step further, really thinking about why the PATOS criteria is so important. So I think about my trauma surgeons. You have a patient that comes in, urgent, emergent case. They take them to the OR. Maybe it's PATOS at that point, or this patient is just, I hate to say it, kind of a train wreck. There's a bunch of things that are going wrong all at the same time. And there are increased risks, but it's not truly PATOS yet. But then it results in multiple takebacks to the OR, multiple trips looking at how did this patient come to be? And it could be this surgeon has 5 SSIs from one case resulting in another, because every time they go back in, they touch that incision, they take them back to the OR. That stops the clock on that first surgery and restarts the clock on the next surgery. So as this patient's taken back multiple times, they can have multiple SSIs. But this is again why that appropriate documentation is so important, because if the patient comes in for the hernia, like previously talked about, and then there's a small bowel resection, well, then there's an anastomotic leak. So basically where they sewed the 2 ends of the bowel basically starts to tear apart for whatever reason. It could be the suturing. It could be the patient's own anatomy starting to just die and it's no longer able to support the tension. Having the appropriate documentation each time they go in is also important, because what this can look like is this surgeon is careless or has poor patient outcomes. It's not necessarily that. Sometimes it's the patient, they're trying to save this patient's life multiple times over. And again, it's PATOS. So again, educating the physicians, the OR staff, even sometimes med-surg nurses to understand this is not necessarily one physician's actions, while doing that, maintaining HIPAA, but explaining it in a way that makes that NHSN very specific conversation with that language of PATOS very plain, very easy to see. And yeah, maybe lunch may not be a good idea to be talking about feculent peritonitis, but I don't know. Healthcare professionals, we kind of like talking about poop while we're eating. So,
different breed.
I guess you should be careful with who you're talking to, but yeah, maybe not the C-suite.
That is very true. Yeah, maybe not the C-suite, but I want to put a finer point on what you said about patients coming in for multiple surgeries. So if you've seen this patient before and you documented PATOS the first time they came in, what I'm hearing you say is each time they come in, we start a new event, and that PATOS language needs to be documented each time that patient goes back to the OR.
Correct. Because the likelihood, let's say the patient comes in on day 1, hospital day 0 or hospital day 1. Then 29 days later, this patient is taken back for a complication. And you have to really evaluate, is this a new complication? Or is this potentially from that surgical site infection? Again, if they come in at 31 days, then it starts the clock again as a whole different procedure, whole different surgery. But unfortunately, yes, this is why no matter if it's previously documented, of course, this patient has a previous infection. Of course, we've been managing that. But that's not how the op report reads. And it's only what's in that op report that's accessible, not the H&P, not the nurse's notes, or even the physician's progress notes. So yeah, this is again why it's an opportunity to go to staff meetings, have those conversations, break those silos, and engage them in the conversation.
And even part of that is this, even only parts of the op note are acceptable. Like it's only the description, if I remember correctly. I haven't read the definition in a few weeks, but yeah, I was trying to narrow mine down to one, and they did not write it in the description.
No, you're exactly right. Because the pre-op note cannot be used to get you, quote unquote, out of an SSI. It has to be in the body of the op note. And that's probably a good, like a silo breaking moment. Is IP is just, we don't get paid more based on the number of SSIs that we call. And sometimes it feels like that's maybe the understanding when we walk into the room is, hey, they just want to report infections. We go through the process of looking at the data, looking at the op note and all of the other factors that go into that, not because we want to get people documented as having an infection or out of it or for any kind of massaging of the data, but everybody has to act on good, accurate data in order to make good, accurate improvements. So I think that's helpful to hear that sometimes IP is just as frustrated by NHSN definitions. Emily, you brought up the example of necrotic tissue or necrosis. And I remember doing SSI surveillance for an AMP or an amputation procedure, and it qualified as an SSI. And I'm like, well, of course it's infected. He's coming in to have his toes removed because there's an infection. Like, how does this not PATOS? And I think that's just some of the communication is, hey, we're doing this for epidemiological surveillance of our patient population. It's not to point blame. It's not to say OR5 is doing worse than OR10 or Surgeon Bob is doing better or worse than Surgeon Becky.
I do want to go back a second to the operative note. In the operative note, everything that is contained within that operative note is open to you. So oftentimes you look at the initial assumed why they're going in. So this is their pre-op diagnosis. But it's when you get into the findings. So the pre-op diagnosis was, let's say that going back to that hernia repair. But all the additional findings that are in there, and then even going to the language. This could be where a physician's documenting murky fluid, yellow murky fluid. Okay, but does that constitute purulence? I need that word. I need you to classify that because through NHSN, that doesn't mean anything to them. They need the specific word. So educating them on, well, yeah, of course it's purulent. Yeah, we just need you to use that one specific word and then continue to use those additional descriptors.
Can you talk a little bit more about the levels too? Because I think that's a challenge in communication is you may see something on one level, but it doesn't come up as PATOS after surveillance is complete.
Yes. So that's very important because PATOS is at the level of the initial surgery. So there are multiple levels. There's superficial, which means that that's within the subcutaneous area. So just that little thin spot underneath your skin. And then you start getting into the fascia level or the muscle level. And that's a little bit deeper. That's what's considered a deep wound, deep surgical site infection. And then you get into organ space. This is when you go in through like in the abdomen, the greater omentum, you get down through into the organ space. So your organs specifically. Now, if the surgery is performed at the organ space level, so this is the bone, we're doing a knee replacement, and the infection is just a little bit of purulent fluid that's coming out from a stitch abscess, that does not necessarily meet PATOS because that stitch abscess that may have been present before the surgery, before they went in, that's not the level that it was identified at. So if the patient is taken back to the OR, they're taking cultures intraoperatively, and they take cultures from the hardware, take cultures from different strata of, the skin, subcutaneous fluid, as well as the deep muscle fascia levels. If it's beyond where they went, or if it's not as deep enough as they went, you can't call PATOS. So going back to the hernia repair and the small bowel resection, if this patient comes in and they have a little bit of wound dehiscence, which means that the wound edges are no longer well approximated and they're starting to open, which means either fluid is coming out. Hopefully it's not full and where you can actually see into the abdomen. But that's another thing to look at. If this is just a tiny opening, it's not meeting that level of PATOS.
Thank you for going in depth on that. And there's so much nuance and so many things here that you really do need both parties working together. IP as experts on NHSN criteria, and then OR as experts on what's actually happening in the case. What are they seeing that we're not going to see during an observation. And that's a big communication piece. So as we round out this episode, Trey and Emily, I want to get both your guys' thoughts on how do we communicate better about PATOS? How do we communicate better about what we're seeing in the trends so that we can build better patient safety into our systems?
So PATOS, again, is not assigned by culture positivity or looking at specifically inflammation associated with one specific factor. There's so many things that teams can get tripped up on, from wound class to excessive explanations, poorly labeled specimens, and then going to clinical practice. And looking at that, there's a lot of things that can get confusing with PATOS, and ensuring that everybody is on the same page. You're breaking those silos. And if you're seeing trends, that you're breaking it down to understand, why are we seeing these trends? Why does the trauma team have so many more SSIs than what would be expected? Well, then you start looking at what their documentation is. Well, they're missing gaps in their documentation. Or maybe there's one physician that went from having no infections to a higher number of infections. So again, engaging multiple people in the team to evaluate the case, to evaluate the environment. And that way you could see, is there something else going on root cause analysis wise? Because ultimately we want to promote good patient health outcomes, because if we don't, this results in disability and early death, which is morbidity and mortality. These people could end up not being able to work or losing a limb, having significant health outcomes. So trying to find ways to mitigate it, and especially identifying PATOS, not only helps the patient understand what they're going to be expecting long term, but also helps the organization remain sustainable, especially in this climate.
I think you hit the nail on the head when you've been talking about documentation, because I think for so much of my IP career, documentation is always so important. And I think that one of the biggest things that you can do, and I think Garrett was right, if you haven't talked to your aura team about what terms are allowed via NHSN. And I actually, while you were talking for a minute, I went to look at the terms just to remember, because even I've been doing this for years, and even I still get tripped up on what terms are allowed versus what terms are not allowed. So I always have to look back at the definitions just to look at it. And if that, I mean, like I said, I've been doing this for a while, and if it trips me up every now and then, I know that it trips other people up. But having a conversation with OR to discuss those terms and kind of have them understand why you're calling things PATOS versus not, because I have had those discussions where they're like, "Well, it was a dirty wound. What more can I say?" And I'm like, "Well, what happened? What led you to think that it's a dirty wound? Was there purulence? Was there?" And I always trip up when I say this. Feculent peritonitis. But if it's not documented there, I can't call it PATOS. And if it's not documented in certain positions, like if it's in the pre-op note, like right before they get to surgery, I can't use that. Like if they did like a CT and they said, "Hey, possible infected wound," prior to them getting into the surgery, and then they go to the surgery, they don't say anything, I can't use that. And I think that's so important to have that discussion, especially with your surgery and your physicians, because a lot of physicians still don't know that either. And they get upset when you call something an infection and they don't agree.
And you made a really good point talking about using a CT, especially if a patient has an abscess that maybe can't be seen and it's identified, it's in the pre-op note, the patient has an abscess, they've cultured this abscess, but they don't document appropriately. That's a problem. And then also working with care teams talking about wound class. A hernia, okay, that can be clean, but once you go into the small bowel, it's now cannot be clean. And so really looking at that AORN criteria for what wound class is, this all goes into the factors of that risk adjustments, because these negatively affect your hospital and can really cause significant problems downstream. So again, it's going back to that documentation, getting that documentation correct, breaking those silos, connecting the right people to the right teams and understanding why we do things a certain way. And then including, you talked a little bit about sterile processing, Garrett. by accident, but totally appropriate.
I always do. No.
And it should be, because sometimes it could be something that you don't think of. There could be an instrument that's used in multiple cases and one surgeon has multiple infections. And then finally, now that we're learning about borescoping some of these complex instruments, understanding that that instrument was probably what was causing infections. Because once that instrument was retired and a new instrument was purchased, all of a sudden these SSIs went away. So again, think outside of the box. It's not just PATOS. It's not just documentation for some of these more basic things, but it's this whole complex piece that comes into this puzzle.
I love that. And an excellent way for us to close out on that silo breaking and communication piece. Emily, thank you so much for joining us today and really giving a masterclass in what PATOS means, the fundamentals of SSI. And if you're listening to this, whether you're from the IP side of the audience or the OR side of the audience, really take this episode up and said, hey, I heard about this and I want to understand more about what you document. I want to understand more about your process for doing surveillance on SSI. And that kind of meshing together of the OR IP conversations is exactly what we're here for. So last thing before we close out today, if you are a podcast listener, which you're here, so you must be, I want to plug Emily Barnard's podcast, Mitigate This. It is wonderful. So listen to this, hit download, go listen to Emily's podcast, hit download on that. Trey, next month when you come out with a podcast, which I hope you do, then we can plug that too. So thank you.
All right, Garrett. So that was a really great episode. I loved our discussion about definitions for PATOS and the thought of bringing teams together. I know we've been joking about taking surgical services out to lunch and just talking about the different PATOS definitions that they know, but that's actually a really good idea to break those silos, because silos in healthcare really do exist and they are really hard to break down sometimes.
Yeah, you're 100% right. And we're all speaking a different language, a slightly different language in a healthcare setting. And PATOS is an opportunity to use the same words across different teams to really identify accurately, hey, this patient came in, they did have an infection when they arrived, and not to get dinged with another SSI, but also an opportunity to really add to the completeness of that patient record. Because patients, as Emily brought up, and I thought it was such a great point, the return to surgery factor for these patients, it's hard on their bodies, it's hard on the surgical teams. And so giving that more complete patient picture is also a huge part of PATOS documentation. I want to thank Emily Barnard again for joining us on the podcast. And Trey, always awesome to have you as a co-host. For our first case and transmission control audience, thank you for joining us today. And remember, infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.